All right, good morning. Welcome to today's Grand Rounds. Once again, today is a pretty important day as we have our residents presenting some research projects that are ongoing. I have just a couple of things. Number one, I'd like to just once again acknowledge the efforts of Dr. Allen as she worked so hard with med students as well to pull off the Bob Trot, our third annual event to honor Dr. Bob Steger, who was one of our dear colleagues who passed away 2 years ago. And Dr. Allen and for charitable to give to Steger Strong and Alex Strong to support both lymphoma and leukemia and childhood cancer. She raised over $10,000. So kudos to Dr. Allen, and we certainly appreciate all the efforts, despite the fact that it was uncooperative weather for everybody who braved that. We certainly appreciate it. Great, thank you. I'll open it up. Any comments, questions, or concerns before we move into our program? And if not, I'll turn it over to Dr. Higgins.
Good morning. This will be our second of 3 planned Grand Rounds presentations by our second and third year residents about the update on their research projects. I appreciate all the good feedback that the last group received. So we'll do a similar order this time. And I believe Suellen is first up.
Good morning. Let me just figure out how to share my screen with everyone. All right, is everyone able to see the screen?
Yes.
Yes.
Okay, perfect. So I'm Suellen. I'm one of the second year OBGYN residents, for those of you who do not know me. Today I'm presenting an update on my research project, which is titled A Smartphone-Based Application to Improve Breastfeeding Rates and Self-Efficacy, a Randomized Controlled Clinical Trial. As an introduction, as we know, benefits of breastfeeding are very well documented. To the mother, it can decrease the risk of hypertension, type 2 diabetes, ovarian and breast cancer. For neonates, it can decrease the risk of asthma, obesity, severe lower respiratory disease, SIDS, otitis media, GI illness, and necrotizing enterocolitis. Despite all of these well-documented advantages, breastfeeding rates remain suboptimal. 58% of women are still breastfeeding at 6 months, and only 25% are exclusively breastfeeding at 6 months, which is the recommendation. There are some non-modifiable factors, such as mothers who are HIV positive or babies who have galactosemia. However, there are some modifiable factors that we can try to influence for our patients, such as breastfeeding knowledge, self-efficacy, and confidence. Breastfeeding self-efficacy can be measured using breastfeeding self-efficacy scale that was developed in 1999, and this has been positively correlated with breastfeeding duration, mothers who have a high self-efficacy. There are many apps out there in the App Store for breastfeeding mothers. Most, however, are mostly just for tracking feeds and pumps and babies' weight gain and things like that. There are a few apps for finding public breastfeeding places, and even fewer apps with just general information and resources to patients. So smartphones apps are needed that kind of cover that gap, that provide information about the health benefits of breastfeeding to infants and mothers, provide educational information about breast milk as normal food for most babies, that counter misperceptions and negative perceptions of breastfeeding, that explain successful techniques for breastfeeding and provide motivation. With that being said, high quality research tested apps could provide a useful and low cost way to disseminate information about the health benefits of breastfeeding to the general population and particular at-risk populations as well. Randomized control trials on the effectiveness of the apps for promoting maternal and child health are also needed. I was doing a little bit of literature review, and I did find one study that was just very recently published in 2020 in AJOG that looked at the impact of a novel smartphone application on low-income first-time mothers' breastfeeding rates. It was also a randomized controlled trial. They studied 170 low-income first-time mothers, and they gave them either an app that was the intervention app, which showed on-demand videos on breastfeeding and neonatal support, and they also gave the control app to the control population or study sample. And they found that it did not truly affect breastfeeding rates. Neither app changed the breastfeeding rates from baseline. Women in both groups rated their apps as providing the best breastfeeding support, though, and intervention app reduced self-reported breastfeeding challenges. So these findings should encourage the use of innovative technology based on interventions in future studies aiming to improve breastfeeding rates or other postpartum health outcomes. We just need to maybe try to tweak and figure out what we can do to actually go from it being a good support to patients to actually increasing the breastfeeding rates. The current study tries to target our populations here at AU because there's a lack of local data on breastfeeding rates, duration, and self-efficacy for our patients, as well as a lack of documented improvement of these factors following educational programs. So we have created a resource that's easily accessible to our patients in the form of a free Apple Store application called Breastfeeding at AU. It was created using information videos and infographics with permission from several sources, including Ecology, Kelly Mom, USDA.gov, ACOG, and the American Academy of Pediatrics. There was a pilot study done on this app that showed 40 immediately postpartum patients that were followed for 6 weeks, and it showed a statistically significant improvement in breastfeeding self-efficacy scores, which, as I mentioned earlier, can translate into improved breastfeeding rates as well. So the study did show a trend towards improvement in exclusive breastfeeding duration. The study population that had the breastfeeding app continued breastfeeding at 65% versus the control population at 32%. The present study has the hypothesis that the app will improve breastfeeding rates, duration, and self-efficacy if offered to patients earlier on in the pregnancy at 32 to 36 weeks gestation rather than immediately postpartum and used throughout lactation. The primary objective will be breastfeeding rates not only at 6 weeks, but also at 6 months postpartum, which is what's recommended to exclusively breastfeed up until 6 months. And the secondary objective will be breastfeeding self-efficacy at 6 weeks and 6 months postpartum. These are some screenshots of what the app looks like. It has some screens that shows just general information and benefits of breastfeeding to the patient. There's a long list of frequently asked questions that the patients can browse through. There's also different timelines of breastfeeding that the patients can surf through before they give birth, when they just give birth, or their first year of life of baby. For instance, in the newborn section, it kind of goes through techniques to getting baby to have a good latch through infographics and videos. And then there's also a section where they can find meetings at AU with our lactation consultant that they can attend. Now these have been more virtual due to COVID. And then there's also a section where they can find resources based on their zip code. The current study design is a randomized control trial with block randomization, and the control group will have the usual care that we give all of our patients, including nursing and physician assistants, lactation consultation, and handouts. And then the intervention group will have all of those things plus the application. The inclusion criteria are pregnant patients at AU between 32 to 36 weeks gestation. They must have an iPhone or iPad with internet access because we only have the app on the Apple Store as of right now. No documented anatomic differences in mother's chest anatomy. Some exclusion criteria includes significant birth complications such as postpartum hemorrhage, seizures, strokes, ICU admission, infants admitted to the NICU for greater than 48 hours, preterm delivery prior to 37 weeks, infants with cleft palate or other palate facial defects, and non-English speakers, since the app is just in English. So our patients here will be enrolled at 32 to 36 weeks at our clinic. We're hoping to enroll 100 patients total, 50 in each arm. At the time of the enrollment, they will be given a pre-study survey to kind of review what their breastfeeding self-efficacy scores are, and some demographics information. And then the intervention group will be given the iPhone app and how to install it, information on that, and then the control group will not. And then we will follow them up at 6 weeks postpartum with a similar survey that includes the breastfeeding self-efficacy scale, as well as some other information about their delivery and things like that. And then that will be also followed up at the 6 months mark. This is an example of one of our post-study surveys that includes the self-efficacy, self-feeding self-efficacy form. This was approved for use by the initial creator of that form, and then some additional demographics information and how they found the app to be useful. As I previously mentioned, the primary objective will be the breastfeeding rates at 6 weeks and 6 months that will be compared for our intervention versus control groups. And the secondary objective will be the change in breastfeeding self-efficacy score over time. Our data analysis for the categorical variables will be performed, will be studied via Fisher's exact test, and for continuous variables, they'll be tested for normality using the Shapiro-Wilk test, and depending on normality, t-test versus Mann-Whitney-Wilcoxon test will be performed. So as of right now, I've completed the necessary training to start the project. I have a medical student on board as well, that she's also completed all the necessary training. The IRB is nearly complete with just some final tweaks pending input from our statistician, who I had a meeting with last week. And then I'm going to register this randomized clinical control trial on the clinicaltrials.gov website, and then complete all the IRB revisions that will inevitably come. And then after that, recruit, get out surveys, and analyze the data. Any questions or comments?
That was an excellent presentation. We'll open it up. We have about maybe 5 minutes for questions or suggestions. Dr. Lehman.
Yeah, that was good. You mentioned your primary outcome is at 6 weeks and 6 months, and what differences do you expect? You didn't mention what you're expecting to find at 6 weeks and 6 months.
Well, unfortunately, probably expecting that at 6 months we'll have some patients that won't follow up with the study, so we'll lose some of those patients, and then also decreased breastfeeding rates at 6 months, or at least exclusive breastfeeding compared to 6 weeks.
Well, remember, your sample size needs to be calculated based on the difference you expect, and it's arbitrary. You know, it doesn't. If you say we expect a 10% difference or a 20% difference in the groups, you should really have something concrete that you're testing. Whether or not it happens is fine, but I mean, just having some primary outcome with the expected differences.
Okay, thank you.
Other questions?
Yes, I enjoyed that presentation. I mean, that's the way to do it, and have a very crisp and clear. I agree with Dr. Lehman as far as the powering of the study, but fortunately, you do have a prior study that gives you at least a direction as the differences between an intervention group and a control group, and that's the one that showed the 65% versus 32%. So if that's the most recent data that you've got, that could be used in terms of powering the study. I think the question really of continuation is going to be important, and I think you might want to include something to motivate patients to continue to record their information. Because 6 months is a relatively long time for new mothers who are busy with their newborns. So there should be maybe a gift or something like that for those that complete the 6-month period. I think you'd get much better follow-up and compliance with continuing to record information. The other thing I would also recommend is that you probably should have the patients create a log book, and the log book can be on a weekly basis, but something so you have a verifiable source of information as to their breastfeeding duration and pattern.
Okay, those are good suggestions. Thank you.
Other questions? Seeing none, we will move on to Dr. Poch in the second presentation.
Okay, let me share my screen. Okay. Let's see. Okay, can everyone see my screen?
Yes.
Okay, great. I'm Alexie Poch. I'm one of the second-year residents. I actually am just starting working on this project with Dr. Lehman and Sasha, and we'll be confirming pathogenic variants of idiopathic hypogonadotropic hypogonadism, or IHH. Okay. IHH is due to a gonadotropin-releasing hormone, or GnRH, deficiency, which results in absent puberty and infertility in the absence of other deficits to the anterior pituitary. A lot of times in medical school, we learn about Kalman syndrome, which is IHH, but with associated anosmia, versus IHH also includes normosmic hypogonadotropic hypogonadism. It's defined by low serum levels of gonadotropins, so FSH and LH, or inappropriately normal, as well as low sex steroids in individuals with absent or impaired puberty. There tends to be a male predominance, with the ratio being about 3-to-1 or 5-to-1 male to female, but the actual incidence or prevalence of the disease is unknown. Estimates are about 1 in 48,000. Besides the typical phenotype you would expect, so with absent puberty in females, you would have absent or partial breast development, you would have amenorrhea, and in males, you would have small testes, as well as lack of testosterone-induced voice changes. There's also other manifestations of the disease. So for instance, the anosmia or hyposmia, sometimes CNS presentations include nystagmus ataxia or synkinesia. Oftentimes you'll see cleft palate or renal agenesis, sometimes unilateral, as well as limb abnormalities. Looking at the background of the disease, so during embryogenesis, GnRH neurons migrate from the developing vomeronasal organ along the olfactory axonal projections. So they travel through the cribriform plate, and then when the axons travel towards the olfactory bulb, the GnRH neurons actually migrate ventrally towards the hypothalamus. The GnRH neuron cell bodies eventually land in the arcuate nucleus of the hypothalamus and then have projections through the median eminence to the hypophyseal portal. In this image here, you can see some of the genes that have been associated with the development of migration, as well as GnRH secretion. And based upon which genes have been identified, some of them you'll see more of an anosmic picture versus a normosmic, depending on where the genes are in the pathway. This is just a refresher of the HPG axis, both male and female. So the hypothalamus releases GnRH in a pulsatile fashion. It goes to the anterior pituitary, which then is stimulated to release LH and FSH, which then travels to the gonads, so the ovaries and the testes, to release estrogen, progesterone, or testosterone. This then works in a negative feedback loop back to the pituitary and the brain. Okay. Looking at the genetics of the disease, so right now there's 57 genes that have been identified for IHH, and these 57 genes contribute to about 50% of cases. This math doesn't completely add up, but about half of them are autosomal dominant, half of them are autosomal recessive, not quite 50-50, and then 5% have been identified as X-linked. There's a growing base of literature that's looking at a digenic or oligogenic inheritance pattern. Digenic meaning that there's two separate genes at two loci that are affected, that when inherited, the child becomes affected. So if you look at the graphic to the right, you can see on the healthy parent, the male, gene A is affected, and then healthy parent B, or healthy parent gene B is affected. So then when they both are inherited, you have an affected child. One of the more famous example diseases is retinitis pigmentosa. Oligogenic inheritance is just that there's more than two, and digenic obviously means two. So the problem with this potential method of inheritance and saying that that Kallman syndrome may be a digenic inheritance is that those genes that have been identified have frequently been the genes that are involved in the autosomal dominant inheritance pattern and that have already been identified as being solely responsible for causing IHH. In addition, some of the mouse models that have been created for the digenic inheritance include genes that have not yet been proven to be causative of the phenotype. This is just a table of the 57 genes that have been identified. You can see on the left-hand column, there's the Kallman syndrome, and then in the middle, there's normosmic. There's the genes that are identified or associated with both disease states, and then the isolated deficiency of one gonadotropic, so FSHB and LHB. The most common genes associated with IHH, FGFR1 is responsible for about 10%, and that's autosomal dominant and has been associated with being digenic. CHD7, which has been found to be responsible for about 6%, is also autosomal dominant and has been affiliated or associated with being digenic, as well as GnRH and TEC-R3, which are both recessive but have been associated with being digenic. The purpose of this project is to determine the prevalence of digenic disease in patients diagnosed with IHH or Kallman syndrome, and therefore once we do that, we can have a better understanding of the inheritance pattern, and this can improve patient counseling. So there's many patients that come to the REI clinic with IHH that are looking for fertility treatment. And in order to appropriately counsel them, it would be important to know which type of inheritance pattern they have. Therefore, they can better choose their fertility options. So far, Sasha and Dr. Lehman have already done whole exome sequencing on 158 patients with IHH and Kallman syndrome at Yale, and then also in London, which then underwent bioinformatics analysis. The raw data came back with over 370,000 variants, but they were then filtered for specific criteria. First, we wanted to look specifically at the 57 known genes associated with IHH. Then, in addition, we wanted to filter down the variants that are rare. So we wanted to look at the mean allelic frequency of less than 0.01. We wanted to look at variants with a CAD score that was greater than 15. And CAD scoring is a tool that's used to see how deleterious or likely pathogenic a variant is. And then after that, we removed synonymous variants, so variants that have been shown to have no significant effect on a resulting protein sequence, as well as 3' and 5' untranslated region variants. We also filtered for what type or like resulting consequence, so, you know, a stop gain, a splice, a frame shift, or a missense variant. Okay, so after that, we came down to about 199 variants plus an additional 78 variants that were identified by the University of London Bioinformatics for a total of 277 likely pathogenic variants. So the future plans would include designing primers for these variants and then confirming the presence of these variants with Sanger sequencing in the lab. And then after that, we can calculate the prevalence. I forgot to mention in the raw data, not only does it have all of those other things, but it also will tell you whether or not that variant was associated with another gene. So therefore, you could calculate the prevalence. Okay, and that's that.
We'll open up for questions. How long do you anticipate it's going to take to complete this?
So based on what Sasha was saying, is she anticipated it would take a year.
Okay, Dr. DeVoe.
That's a very interesting study, and I guess in terms of classifying it, this is really more or less a pilot study, just looking at prevalence. But I think the question is, you're going to have a lot of variants to look at, and how are you going to rank those variants in terms of severity? Do you have the phenotypes of the people to compare with?
That's a good question. I know in the literature so far, the presence of digenicity has not been shown to have a more severe phenotype. But as for the actual phenotypes of the 158 patients, I would have to ask Sasha or Dr. Lehman if they have record of that. My suspicion is yes.
Yeah, we do have the phenotype of all those patients. And it's a good question of ones to rank, how we're going to rank them. I mean, we're going to pick ones as if it was a clinical lab. In other words, the variants that are identified, whether they're reported to be deleterious in the literature. Otherwise, they're not really known to be causative at this time. And part of the reason why this should be interesting is people have studied digenicity a lot, but it depends on what genes were known. At the time where there were 5 genes, it's different than 10, 20, and whole exome is a more unbiased approach to determine the prevalence of digenicity, which is estimated to be 2% to 20%, depending who you read.
I have one more question. Do we know, in terms of the affected individuals, whether their parents have been also tested?
We have family members for some of them. The ones we find variants in, we definitely test the parents and any relatives, so they will be looked at.
Dr. Diamond.
Yes, I think this will be a very important and informative study. But what was stated as to why you were doing this is that you thought this was going to help you determine therapy for these individuals, and I'm not quite following that. I don't know that you need that in order for this to be an important study and to do it, but I'm not sure what you will find about these diagenic disorders will actually affect what you would do differently as far as the approaches you're going to be taking to try to help these couples conceive.
Yeah, that's reasonable. I think having, I guess, yes, you're right, the study could stand alone, but it would be helpful for them to know, based upon what inheritance pattern they have, whether or not they're likely to pass it on to their child.
Yeah, so for genetic counseling, it could be important. It's like, as Dr. Diamond said, I don't think it's going to change the way we would treat people, but it might affect the recurrence risk.
Yeah. Yes, and perhaps they would decide they then want to use donor oocytes, but that's, again, I think your study stands on its own without that as a justification or a purpose that you're hoping to determine.
Any other questions? If not, we will move to our presentation with Dr. Griswold.
Thank you.
Okay. Okay, can everybody see this?
Yes.
Okay, and hopefully my slides will advance this time. I've had trouble with that in future grain rounds. Okay, so for those who don't know me, I'm Lauren Griswold. I'm one of the third-year residents here, and my study was looking at spontaneous pregnancy rates after Hysterosalpingogram, or HSG, and Saline-Infusion Sonohysterogram, or SIS, in infertile women. Okay, so evaluation of tubal patency is one of the first steps included in the evaluation of a woman with infertility. The gold standard for tubal patency evaluation is laparoscopy with chromoperturbation. The gold standard for non-surgical tubal patency evaluation is HSG. And there have been several previous studies that have shown a 2 to 10% increase in pregnancy rates after HSG without any further intervention. SIS is an alternative to HSG for tubal patency evaluation in patients at low risk for tubal disease. SIS is beneficial because it is low cost, there's no exposure to radiation for the patient, and it's fairly easily accessible and can be done in the office rather than a fluoroscopy suite. There have been very different studies with contradictory results regarding the effect of SIS on subsequent spontaneous pregnancies. And so we are unsure whether SIS is as effective as HSG in facilitating pregnancy. So therefore, the objective of this study was to compare spontaneous pregnancy rates after HSG and SIS in infertile women at low risk for tubal disease. This was a retrospective cohort study. We reviewed women of reproductive age undergoing infertility evaluation with HSG or SIS between 2016 and 2019 here at AU. Our exclusion criteria included risk factors for tubal disease, known pelvic adhesions, male factor, infertility, and patients who were lost to follow-up. So initially, we thought we were going to have a very large number of patients to include in this study. We started with a large data set based on the, we used the code for the catheter that's used in the SIS and HSG in order to poll the patients, and started with over 1,000 patients. So we thought we would be fine when it came to power, but then 986 patients were excluded. 271, they had undergone SIS for the IVF trial of transfer, so it wasn't for evaluation. 230 had no infertility diagnosis. Most of them were women with postmenopausal bleeding that had SIS or had HSG for uterine evaluation.
214 patients were lost to follow-up. 71 patients had a diagnosis of recurrent pregnancy loss. 51 underwent both SIS and HSG within 6 months of each other. So it was no way to tell if they did get pregnant, which procedure had led to that, if either of them. 51 patients underwent pelvic surgery shortly after HSG or SIS prior to eventually becoming pregnant. So it could not be said if it was a result of the surgery or the procedures. 59 patients were not yet 12 months out from HSG or SIS, so they couldn't be included because of incomplete data from that standpoint. And then 39 patients had severe male factor infertility, so either no male factor at all. No male factor at all, severe male factor infertility. So in the end, 170 patients met inclusion criteria, which was not nearly as many as we thought we would have. Based on those 170, here are our overall patient demographics. The groups were very comparable in age, AMH, some had prior pregnancies and prior live births. As far as surgical history, which was one of the other variables we looked at, it was comparable between the groups as far as who had prior surgeries, no prior surgeries, as far as concern for pelvic adhesions. So again, 170 patients met inclusion criteria. There were 93 patients in the HSG group and 77 in the SIS group. Of the patients that underwent HSG, 26 patients, or 27.9%, spontaneously conceived, while 21 patients, or 27.2%, in the SIS group spontaneously conceived. These are obviously not statistically significant. They're very comparable rates. There's no statistically significant difference between these two rates in the two groups. So in conclusion, there were comparable spontaneous pregnancy rates in infertile women at low risk for tubal disease after both the traditional HSG and the newer alternative SIS. As I mentioned already, this study was limited by being severely underpowered, and it was a retrospective study. So I think there definitely needs to be more studies in the future that either retrospective with a larger power, larger patient group, or if possible, a prospective randomized study to look at spontaneous pregnancy rates between the two procedures. And here are some references for the background, and that is all I have. This is very rough presentation. I apologize. But if there are any questions.
Dr. Lawrence. I'm sorry, Dr. DeVoe.
Yeah, I think that's a topic that has been sort of kicked around the block a number of times since the use of SIS has increased. And one of the things that's sort of missing in that study is the actual findings on SIS. In other words, comparing that with the findings on HSG. They're different techniques, but they make some statement about tubal patency. And we're assuming that there's some aspect of tubal flushing that improves pregnancy rates, but I'm not sure that you can draw a direct cause and effect line between the two, because you excluded patients with known tubal factors already. So one thing I might suggest is that this is the kind of study that asks for perhaps collaboration with other REI divisions in related institutions. And the reason I bring that up is you obviously need more numbers, but you can also get those numbers by reaching out to other people, who've done this and who have archived records of patients. But I still think that one of the things that might improve this study, such as it is looking at the actual findings that were denoted for both imaging methods.
Yes, sir. Thank you. And we did look at the findings. It wasn't included in this particular abstract that was submitted, but that is something that is in our data set and something we can look at more closely. So we do have that information. And I agree about maybe some collaboration because I definitely need more patients.
Dr. Lehman.
So yeah, this is an important question. I've a couple questions. What difference were you expecting? And you mentioned how you had over 1,000 cases to start with, but when you got to what you were going to look at, I mean, what difference would you expect? And number two is, I think there's unfortunately heterogeneity because very few of our patients are going to be spontaneously trying to get pregnant. And after the procedure, many of them are getting ovulation induction or insemination, and all of that would need to be sorted out as well. So I wondered, when you said spontaneous pregnancy, do you mean how many months, and were they on any medicines? I assume it means non-IVF, but probably could, many of the other patients are going to have had other treatments.
Yes, sir. We looked at, obviously I had excluded the patients that got IVF. We looked at 6 months and then 12 months. And the patients that did spontaneously conceive, by the time they had, most of them had not been started on any further treatment as of yet. But we did make note of the ones that had been, some of them I believe had been started on ovulation, like medications. But as far as those rates, none of them were actively undergoing SIS or IUI. As far your first question we were expecting ideally 10% as far as a difference, but I don't have a good answer for you on that one.
Dr. Diamond.
Yes, found this to be very interesting. Want to follow up a little bit on some of the comments Dr. Lehman just made. First of all, I think, at least in the REI community, when someone talks about spontaneous conception, that usually means without any kind of fertility drug or insemination to try to help the individuals conceive. And for individuals going through the REI clinic, I would think there would be very few that would have no attempts at conception after one of these procedures at 6 or 12 months. I would expect that they would have been on some sort of active therapy. But that's what I was going to suggest might be additional information that you could look at, is how many cycles did they have where they were spontaneously trying to conceive. And while you didn't see any differences in the total pregnancy rates of 27.2, 27.9 or 7, there may have been a difference in the time to conception, which would be interesting to look at. Last thing I'll just comment on, you said there's a need for a long-term prospective study to look at this, but I would encourage you to do a power calculation with the preliminary data that you have of the differences between the two groups. And I think you're going to find you're going to need an astronomically sized group in order to be able to try to see a difference between the two, or alternatively, to do statistical assessments to show that there is no difference between them.
Yes, sir. Thank you.
Did you look at the quality of the test, but comparing the two? Did you get different information between one test versus the other?
What do you mean by quality?
In other words, how adequate was the SIS compared to the HSG? Because sometimes the quality of the test is going to give you what the results are. So I just wondered if there was some quality control, or is the same person doing all the HSG? Did you have a group of people doing HSGs and the ultrasounds, or you just have one or two people doing it?
It was a majority Dr. Jordan and Dr. Lehman. And I think a few were from Dr. Brocta, but she had just been getting started during that time period. So a large majority were just Dr. Jordan and Dr. Lehman. So as far as quality, I mean, it's hard to tell based on just like notes without actually seeing it. But the fact that they were done by two people, I feel like you can say that it was comparable.
Okay, any other questions? Want to thank all three presenters today and the feedback that they were given. And unless anybody has other comments, I hope everybody has a great day.
Great. Thank you so much. Y'all have a good day.